Thanks for downloading and welcome to Take Orally, the podcast from Dream Queen's Medical Centre at Nottingham. In this episode we'll be discussing taking a gastrointestinal history. As ever, all information is correct at the time of recording. Any and all guidelines mentioned are correct for Nottingham University Hospital's NHS Trust. Other trust guidelines may vary. All views and opinions of the speaker's own. Hello and welcome back to Take Orally. This is another early clinical experience podcast. Once again joined by Lucy. Hello Lucy.
Hiya.
And we are discussing taking a gastrointestinal or GI history.
GI history taking, indeed.
Another very common presentation, a very common thing that we have to do in A&E, and with some very important red flags that we need to pick up in our history.
Yeah, absolutely. So you're sort of leading on really from the cardio respiratory histories that we've discussed in previous podcasts in the context of your consultation. Again, just reiterating that this is the most important part of your interaction with the patient, and 80% of the time you should be able to sort of come up with your diagnosis really from taking a thorough history. That being exploring the presenting complaint in detail, using some form of system, whether that be Socrates or whatever you choose to use really, and then exploring the symptom to death, as it were, so getting as much information as possible, starting with nice open questions for your patient to be able to describe what's happening, and then once they're ready, going to more closed questions about the pain to really sort of gain an idea of what the underlying cause is. We're developing a little bit more in terms of exploring the symptoms related to different differentials as well, and how they may well present, and specific sort of risk factors for different differentials as well. We can sort of touch upon that really. So in terms of the cardinal symptoms, once we've already explored the main symptom, whether that be sort of pain, essentially would be one of the biggest reasons people attend either primary or secondary care, so abdominal pain. So once you've done your thorough Socrates on the specific symptom they present with, then moving on to your other cardinal symptoms of the GI system. So that being abdominal pain, distension, hematemesis or vomiting, and being probably quite specific about sort of triggers for that and colour. There's a lot of people that present with hematemesis, or you see the words coffee ground vomit.
Coffee ground vomit, which gastroenterologists love. They love that expression. Yeah. I'm not sure if you've done any podcasting with the gastroenterologist yet. There is enough a GI Bleed podcast, which I'll draw people to at this point.
And do they touch upon coffee ground vomit?
I think there is a discussion about coffee ground vomit at that point, yeah. We also have an acute abdomen podcast as well, which I think I'd signpost people to. That's
brilliant.
a two-part that goes through some cases as well. So if we're thinking about pain, that's another good one to look at.
So moving on from there, thinking about bowel habit, so constipation, diarrhea, whether there's blood present, whether that's fresh red blood, and whether it's melena, so metabolised blood being seen.
Once smelt, never forgotten.
Once smelt, never forgotten. Some people have it as a name, don't they?
They do, melena.
It's a popular woman's name, yeah.
Chlamydia is also a girl's name as well. And Candida. There we go.
Thinking about other symptoms such as weight loss and appetite, so anorexia could be either an associated symptom or a presenting symptom as well. Dyspepsia, difficulty in swallowing, or donophagia, where you have pain in swallowing, and I guess there needs to be some exploration around that as to whether it's solids or liquids that are causing the issue, or if there is a difference between the two. Again, you need to be doing this to death and thinking about how long has this been going on, has it been gradually building up, did it start with a difficulty in swallowing and then move to a painful swallow, and just really getting down to the I hate using this word, but minutiae of the symptom, and then the final symptom being gastroesophageal reflux or GORD. if you're looking at the diagnosis.
Very often a diagnosis of exclusion in A&E.
Absolutely.
Chest pain is chest pain, and we have to think about that. But okay, good.
So in addition to that, I would say that you've got your cardinal symptoms, but then you have your additional systemic symptoms that I would always ask about, or certainly look for. Say things like jaundice, fever, malaise, and fatigue in patients. They are systemic symptoms, but may be related significantly to the GI system. So to ask about those as well. It's a tricky thing, isn't it? GI. I think from a perspective of a newly qualified ACP or someone training as an ACP, this is unfamiliar. Cardiorespiratory is something that's really honed in upon, whether it be medical or nursing training, whereas the gastrointestinal system is slightly more foreign to most.
Imagine you're on a boat. You're in your boat and you're in the sea and you're far out from land, and you look over and you see a big shadow underneath you. So there is something there. So your patient has abdominal pain. There is some pain. Yeah. But the question that then goes through your head is this a whale or a dolphin? Something nice and friendly that's there? It might knock you a bit, but it's going to leave you alone. Or is it a hungry shark that you need to get away from and do something about very, very quickly? And the data from
before it snaps up your registration.
Absolutely, before it snaps up your registration. And the data from RChem, I believe, is something that if you cut A&E attenders with abdominal pain, 40% we don't find a cause, 20% is appendicitis, 20% is biliary, and then there's 20 something else, and that something else obviously carries an awful lot of things.
Yeah, absolutely.
Such as
some of the really scary stuff.
AAA, ectopic pregnancy, perforation.
Really do not miss things.
All the stuff that you should never miss. So, there's a lot there.
I think you've covered it there, actually, that sometimes I feel a bit cheated if I don't come to a conclusion, and I've not found a clear answer by the end of doing a thorough history and examination on the patient, or even with investigations. Actually, there's no clear cause identified, but actually, I think sometimes GI symptoms are a long game, aren't they? There is further investigations that need to be done, and they're not necessarily something you can do either within primary care or, from my perspective, from an A&E perspective. So there is some specialism that might need to be involved as well. Essentially, they're a hard bunch, aren't they? But I guess the main thing is to know the rules of the scary stuff that you would not want to miss. And if you focus on the particular demographic of patient that might present with the scary stuff, then you're less likely to miss that. So it's got to be on your radar, really. And certainly from the lecture for the ACP Masters afternoons, we focus on looking at pregnancy as your risk group, presenting with abdominal pain, not with the obvious things such as labour.
Although it does happen.
Thinking about how pregnancy alters your anatomy grossly within the abdomen. They present with things all pregnancy related, clearly, but they're not null and void from presenting with everything else the rest of the population could present with. So essentially you've just got a Pandora's box. Can I say that?
And what percentage of young women coming to A&E are pregnant?
I have no idea, Jamie.
100% unless you check.
Absolutely.
So always check. If you've got a woman of reproductive age, she's pregnant until you check otherwise. So it's always important to think about ectopic pregnancy. This is the unilateral pain. Obviously, it's the early stages of pregnancy, so they may well be known to be pregnant and not have had their first scan yet. They may have had risk factors for ectopic pregnancy, so a previous ectopic pregnancy, pelvic inflammatory disease, an IUD in situ. Always got to think about those things.
I guess one of the, you obviously mentioned, Jamie, about making sure you're doing your pregnancy testing. I even if somebody says that there's no chance they could be pregnant, I'm quite specific with them on, so there's no chance of pregnancy, are you taking contraception, are you using contraception, and have you had unprotected intercourse? Because actually if the answer is no, I'm not on any contraception or use contraception and I'm having unprotected intercourse, then actually there is always a chance that you could be pregnant. Whether they say they had their most recent period is kind of irrelevant really. Essentially if they're within reproductive age, then doing a pregnancy test, both urine and a blood HCG if you're able to.
Yep.
I would say in terms of red flags, I think you mentioned it, in terms of patients presenting with unilateral pain, particularly in early pregnancy, typically before around sort of 8 weeks, would be presenting time for things like ectopic. Essentially it's ectopic unless it's in a woman of reproductive age until proven otherwise. Less so after about 10 weeks, because actually the embryos got so big by that point it would have caused catastrophic damage. I guess you just need to be very clear on times of conception, and if that's not clear at all, then ectopic is always on your radar. Appendicitis is really hard in terms of thinking about pregnant women, even in the early stages as well, with sort of changes in anatomy. Obviously there's stretching of the uterus, but also the round ligaments bilaterally, meaning that patients can come in and complain of sort of sharp stabbing pains, but equally could be something like appendicitis or ectopic pregnancy. So you need to have that suspicion, an index of suspicion on your mind really all the time. Obviously we spoke about the obvious obstetric issues, so labour, but also things like placental abruption, which obviously are life-threatening for mum too, and things like placental infarct, which is life-threatening for fetus. And having obstetric help as soon as possible really if you're concerned about any of those things. And then alongside the other obstetric risks is things later in pregnancy more so, but thinking about sort of preeclampsia and HELP syndrome, so hemolysis, elevated LFTs, and a low platelet count in the third trimester is sort of a precursor really.
There's also a preeclampsia podcast if you want to listen about that.
plug
Always plug on message.
And moving away just from the obstetric risk, but things that can increase are things like cholecystitis is one of the things, so gallstones within pregnancy can increase, and in the postpartum period as well. But cholestasis is obviously a risk, and they would need an obstetric review for that, and potentially early induction. The other things that are obviously at risk are things like the usual suspects of things like constipation, slower gut transit, etc. Piles, unfortunately. It's lovely being a woman and having a baby. So all of the things that we potentially could get in the normal population.
The non-pregnant population. So another risky group is our elderly patients, and
so
I think we've all got some stories about near misses and or maybe misses in elderly patients coming in with abdominal pain. There was an RChem alert that they have a 6 to 8 times increased mortality coming in with abdo pain to a non-elderly patient coming in with abdominal pain.
Yeah, that was back in 2016, where essentially they recommended that anybody, an older person attending ED, would essentially your investigation of choice is going to be a CT.
So at least here in our department, that you have a discussion with a senior, if nothing else. You discuss your patient with a senior. But yeah, they usually have other comorbidities, which makes anything they have difficult. If you're a patient with severe COPD who's got cholecystitis, you're going to be more unwell than a patient without COPD coming with cholecystitis. They're on medication that masks things, so they may be on a beta blocker, so they never become tacky with you.
They don't mount the tachycardia response.
They lose muscle mass, so they don't guard. Their somatic sensation, visceral sensation, somatic sensation isn't as good. So they appendicitis in the elderly isn't going to be the classic umbilical down to right. So it's a minefield basically with them. Approach them cautiously.
Absolutely, and I think probably don't be reassured if they've had a strong painkiller such as opiates, that they don't now have pain, because actually the principles still apply, that they had bad enough pain that required opiates to relieve. In itself is a bit of a red flag, isn't it? So they're a risky group, like you say. Senior help early, really, and discussion, and have a higher index of suspicion of something serious underlying that. Alongside, you mentioned about sort of comorbidities, so thinking about people with multiple comorbidities on medications, and we see many patients on multiple medications, some of which maybe they do need to be on, some of which may have just been re-prescribed, and actually there is an emphasis that maybe we should have more regular med reviews for patients, to see if actually what they're on is still applicable. But in terms of the medications that make me bristle a little bit when somebody attends with abdominal pain are things like methotrexate. In terms of not, again, mounting a normal response, and having a higher incidence of being susceptible to things like infection. Long-term steroids as well. Slightly concerning. I guess the other thing to add in there would be things like NSAIDs. Yeah.
So is there a risk of irritating the GI?
Absolutely.
The gastro.
And I always remember a patient that attended. She was young. She was early 40s, and had new braces fitted, and had been taking, because it was quite painful, obviously, having your teeth shunted into different directions, and had been taking NSAIDs for I think probably a 4-week period, and presented with hematemesis, so frank fresh red blood, and she just irritated her stomach lining so much by taking them for such a prolonged period of time. So that's an important one to think about. I guess the other thing to think about is our unintentional overdoses. So patients presenting with a pain, whether that be abdominal pain or dental pain, as one of the typical ones that we might see, and have just taken too many, trying to alleviate their pain. And I guess alongside that are our intentional overdoses, obviously a worrisome group in terms of abdominal pain and the effects on the liver.
Cancer as well. So if you have a patient who's known to have cancer.
So cancer, known to have cancers, or previous cancers. That are assumed to be cured.
In remission,
or in remission.
Or abdominal pain along with the night sweats and weight loss and all of that stuff.
All of your worrying history. Absolutely. I guess the concern would be sort of previous surgeries as a result of previous cancers. So if they've had a bowel resection and things in the past, in addition to everything else that other patients might present with as well, they've got a higher risk of things like obstruction, adhesions, perforations. So a concerning group from that perspective.
Another concerning group is the patient with recent surgery. Now, this is something that was sort of hammered into me quite a bit by one of my consultants when I was at medical school, about any recent surgery, regardless what it was, whether it was laparoscopic, regardless of where the anatomy was, regardless of how unremarkable the surgery was, and they've been fine, if they are coming back, and his in particular was 10 days, so 10 to 14 days post-surgery, consider that something has been nicked, the anastomosis has started leaking, or there was some sort of injury that was done that hasn't been picking up, and there's a leak, there's a collection. something is going off in that abdomen. And actually it's a doctrine I stick to, and it served me really, really well, that patients coming in who look quite well, but they've had a recent surgery, they've had a scan, and they've been shown to have something, a collection or a leak.
Yeah. No, the only other thing is obviously the increased risk, just generally for surgery, so increased risk of clotting, so thinking about bowel ischemias and things like that, as one of the other reasons. But no, essentially, you've, in a nutshell, said it all.
Yeah, absolutely. I think it's a rough rule of thumb. So it was like a few hours post-surgery, hemorrhage. You're not going to really see those in A&E, but a few hours post-surgery, complication is hemorrhage. So, your unwell patient is going to be bleeding. A few days post-surgery, wound infection, usually 10 to 14 days, bowel leak, or something like that, or to those effects. And I stick to that, and it's served me very, very well.
And then thinking about just generally red flags, alongside all of those, as if it wasn't complicated enough. Red flag, I think you've touched on a few of them already, actually. So an indicator that something more concerning is going on, and increases sort of the probability of sort of life-threatening conditions. So alongside all the things that we've discussed so far, you mentioned about weight loss, night pain, or rectal bleeding. And without really trying, that's always something that is concerning when you think about those symptoms with somebody presenting with abdominal pain.
And an iron deficiency anemia, that's another one, isn't it?
Absolutely.
Any change in bowel habit.
Change in bowel habit. And we talk about constipation as a diagnosis, but actually it's a symptom in itself, really. And is a consequence of something else happening. So it's always a differential of exclusion in my mind, but actually there is normally something that's causing the constipation. It's sort of finding the reason for that, and certainly would need further investigation if there was no response to that. So dyspepsia is another sort of red flag in the over 55s, thinking about the need for endoscopy with a potential cause of malignancy, or even pancreatic cancers, which are so elusive in how they present.
Absolutely.
That you've got to have, again, a high index of suspicion for those.
Yeah, so they say about ovarian cancer as well, isn't it? There's another podcast on that as well.
Brilliant.
But the older patients, that vague abdominal pain, that long-standing vague bloating, back pain for your pancreatic cancer, and this unfortunately is those things that can make the news, going, oh, my cancer was missed for 2 years and things, and it's tragic, but these are very difficult things to pick up.
Really hard. I would also say that in terms of, and I think this is something that's been locally within Nottinghamshire, has been on the news in terms of our incidence of alcohol dependency, is markedly high in comparison to the rest of the country, and thinking about alcohol history, not just on patients presenting with abdominal pain, I would say most patients that you see, ensure that you do get an accurate alcohol history, because there's an intervention thing that we would need to do at that stage to say, do you know what, you're drinking heavily and we need to nip this in the bud.
Yeah, absolutely.
Before it becomes out of hand. But if you have somebody who's presenting with upper GI bleeding, then there needs to be a really clear alcohol history on their alcohol intake, to assess whether they're going to be at a higher risk of things like esophageal varices as a cause of their bleed. So very key not to miss that aspect of your history.
Absolutely.
And I also think probably try to sort of check yourself in terms of your own bias, and thinking about somebody who presents with abdominal pain but has a history of, for instance, irritable bowel syndrome or a chronic history of endometriosis, again are at risk for all the other different differentials for abdominal pain.
I mean, I always find with these, if they've got recurrent pancreatitis or endometriosis, mind you, most chronic problems, is this like your normal pain that you have with your pancreatitis? And as you said, we do see patients sadly coming in very frequently with alcohol pancreatitis, and they'll go, yeah, this is exactly like my pain, it started the same, it's exactly the same, and that's in a way reassuring, it helps us. But if they do say this is different, this isn't like my normal endometriosis pain, this is different, this is in a different place, etc., etc. Listen to that.
Listen to it, because actually the patient generally knows whether it is that or not.
Absolutely.
I guess that's sort of my final point really on this, is that recognise your own biases, remember your red flags with abdominal pains, and once you've completed your full and thorough history, you should have a few differentials in your mind from that on how you're going to then do your examination and complete your examination, and then where you're going to go in terms of your investigations and appropriate investigations for your patient group.
Absolutely. Good. Anything else, Lucy? Is that GI history achieved?
That is GI history achieved.
Marvellous. Thank you so much, Lucy.
Thank you.
Bye-bye. That was the Take Orally GI History podcast. Remember, you can find the blog entry for this podcast, as with our other podcasts, at www.takeorally.com. Remember, you can subscribe to Take Orally on both SoundCloud and Apple Podcasts. Take Orally is also on both Facebook and Twitter. For more information about research and education opportunities with emergency medicine, acute medicine, major trauma, remember to check out NUH Stream on both Facebook and Twitter.